Hey everyone, welcome back. This is Dr. Dilip, your internal medicine faculty at Cerebellum. Today we're going to have a quick discussion of most, if not all, of the medicine questions that was asked in the NEET PG 2024. And you will be really surprised to know how many questions has been asked in medicine. And you might be arguing with me, asking that these are not the exact lines from the questions that we have discussed in the ENDs as well as from the notes, but they are kind of transcripts from the concepts that we have discussed. You'll be understanding as we move through the discussion. And I purposefully left on like 10-20 questions in each shift because they are more into the basic clinical sciences. But trust me, like there are plenty of questions. And before starting the discussion, let me give you a quick disclaimer. It's a recall based discussion and not the actual questions. Be very clear about it. And we all know that the actual questions were quite lengthy, in fact, extremely lengthy. And this is just the essence of those questions and not the actual questions. Few questions may be mixed up between the shifts because I'll be initially discussing the first shift, then I'll be moving on to the second shift. But if the questions are mixed up, please don't blame me. And some questions may seem ambiguous because there is inherent variability in the recall. And even in the previous exams, we tend to see some variability, but this exam contained a lot of questions which were extremely lengthy and students did struggle a lot to get the recall. But anyways, even we did struggle and finally we got the recall and here we are. And of course, there will be some variability and please don't get confused with regards to that as well. And purpose of this recall session is to understand the essence of what's asked so that it will be useful for your own personal assessment as well as for the future exams, but not to know the actual exact questions being asked. So with that disclaimer, let us move on to the discussion. Here's your first question from shift 1. A 54-year-old female present with shortness of breath. On examination, she had bibasal crackles and third heart sound, which is pointing towards a probable heart failure. Echocardiogram revealed a poor cardiac contractility with an ejection fraction of 33%, which means this patient is definitely suffering from heart failure and reduced ejection fraction. Which of the following drugs can reduce mortality? We know there are 4 important drugs often referred to as the Fantastic Four, the RNase inhibitors and the ARB group. Then we have the beta blocker group. Then we have the MRA group, which includes spironolactone and eplerenone. And finally, we have the SGLT2 inhibitor group. All of these drugs can reduce mortality in terms of HF-REF, but the options are all about beta blockers. So we know that there are 3 beta blockers that can reduce mortality and improve survival in the context of HF-REF. So what are those beta blockers? We had a mnemonic for that as well. These are called as the MBC beta blockers, which includes the metoprolol, bisoprolol, and carvedilol. We know that metoprolol and bisoprolol are kind of cardioselective drugs, but carvedilol is not cardioselective. In fact, it works on beta 1, beta 2, and it has alpha inhibitory action as well. So among the 4 given options, the easiest one to choose is going to be bisoprolol because that's been shown clearly to reduce survival, to reduce mortality and improve survival in terms of HF-REF patients. Let us move on to the second question. A 38-year-old patient presents with chest pain and hoarseness of voice. For the last 1 month, the MRI of the patient is shown. Which of the following is the likely diagnosis? If you look at the MRI, or probably it could be a CECT image as well, it doesn't matter. You can clearly notice that there is a saccular aneurysm coming from the aortic arch. And even in 3D reconstruction images, you can clearly notice that there is a saccular aneurysm that's coming out of the aortic arch, and this may probably be compressing on the recurrent laryngeal nerve, and probably that could be the reason why this patient is having hoarseness of voice. So right answer for this question is a simple, straightforward option A. Let us move on to the third question. A 33-year-old patient present with chest pain, shortness of breath, and edema. On examination, his pulse was irregular, probably pointing towards an atrial fibrillation, and JVP was elevated. And JVP did show a prominent Y descent. So we all know there are very few causes of prominent Y descent. In that, one of the important causes is constrictive pericarditis. And the second most important cause, I would say, is tricuspid regurgitation. But here, the clinical picture is not favoring tricuspid regurgitation. So if you have a prominent Y descent in constrictive pericarditis, this is also referred to as something called as Friedrich sign. We have discussed so many times. And on auscultation, he had a high-pitched diastolic sound. In the context of constrictive pericarditis, this high-pitched diastolic sound must be a pericardial knock. And what is the diagnosis? Of course, we have discussed so much. I'm not going to tell anything other than constrictive pericarditis as the answer, right? End of discussion. Let us move on to the fourth question. why a patient who has aortic stenosis experiences easy fatigue as compared to a patient with aortic regurgitation. So we know that aortic stenosis is a condition where going to have a fixed LVOT obstruction, and because of that, there's going to be considerable increase in the pressure of the left ventricle, and there's going to be pressure overload, and that's the reason for left ventricular hypertrophy. And the hypertrophy left ventricle is going to suck in a lot of energy. It's going to demand a lot of energy, and there's going to be a lot of myocardial oxygen consumption that can even cause angina and heart failure over a period of time. We have discussed all those things in our lectures. And right answer for this question, of course, is going to be option A, because pressure overload is the main factor that causes problems in patients with aortic stenosis. And this is going to cause more myocardial demand compared to that of volume overload. That's absolutely a true statement. Option B is wrong because the vice versa is wrong. And option C is definitely wrong because A is going to cause pressure overload for sure. And option 4 states that preload increases myocardial oxygen demand more than afterload. So preload increase means it's an alternative statement for probably I can say volume overload, and afterload increase means it's an alternative statement for pressure overload, even though not exactly the same, but you can equate like that. So right answer for this question is going to be option A, simple. Coming to fifth question, a patient with hypertension CKD presented with generalized tiredness, ECG is taken and shown. What is the diagnosis? What we have in the ECG. So this is a straightforward case of hyperkalemia because this ECG is showing tall T waves. And of course, this patient is having white QRS, which indicates conduction blocks. And this ECG doesn't have any P wave. If you look at the rhythm strip in lead 2, you do not have any P waves at its usual location. Cannot see any discernible P waves, which indicates an atrial paralysis, absence of conduction within the atrium, which is very classic of hyperkalemia. Hyperkalemia is a very unique condition because it produces a combination of both conduction blocks and it also causes overexcitation causing arrhythmias. So it's a very unique condition. So right answer for this question, you want me to repeat, you can say by yourself, it's going to be hyperkalemia. Right. Let's go into the sixth question. A 53-year-old male patient who is a known case of COPD developed breathlessness and is on mechanical ventilation. He suddenly developed hypoxia, and on examination, he has reduced or probably absent breath sounds on the left hemithorax with increased peak inspiratory pressure. So what is the likely diagnosis? This is a question based on a discussion on how to evaluate a patient who is experiencing a acute ventilatory deterioration. So whenever a patient experiences an acute ventilatory deterioration, so what is the first thing you need to look at? You have to look at something called as peak inspiratory pressure. That's called as PIP. So you have three options here. So PIP can be normal, or PIP can be reduced, or PIP can be increased. Whenever the PIP is normal, you're going to think about some extra pulmonary causes or extra parenchymal causes like pulmonary embolism for that matters. And if the PIP is reduced, you have to suspect leak elsewhere. In case if the PIP is increased, then it could be due to either increased resistance in the airways or probably due to poor lung complaints. So how will you find out? So in this case, you have to find out something called as plateau pressure. In case if the plateau pressure is normal, you can assume that the problem is increased airway resistance, where you can think about possibilities like sudden bronchospasm or even like mucus plugging of the tubes. In case the plateau pressure is increased, you're going to think about reduced pulmonary complaints, reduced lung complaints or reduced pulmonary complaints. So this is the algorithm that we have discussed. And here the patient is having increased peak inspiratory pressure. So definitely I can rule out something called as pulmonary embolism. And it is not acute exacerbation of COPD because there is no mention about the normal plateau pressure. Plus at the same time, here patient is having like reduced or absent breath sounds on one side. So that doesn't really go with acute exacerbation. So I can ignore that option as well. And it's not really pneumonia. Patient can have pneumonia, but again, this reduced or absent breath sounds on one side is not going to typically indicate a pneumonia. So pneumonia typically going to expect something like bronchial breathing or probably consolidation in imaging. So that's not given here. So I can easily exclude that option. The right answer for this question is pneumothorax, which is a classic condition in ICU patients because of barotrauma that can cause an acute ventilated deterioration, sudden hypoxemia. So where your peak inspiratory pressures rise all of a sudden. But in this case, you will have increase in the plateau pressure as well. So that's an additional point that you can know now at least. Let us move to the next question. A patient underwent a major 14-hour-long surgery in prone position and continues to be on ventilator during recovery. What is the advantage of positive end expiratory pressure in mechanical ventilation? The main reason why we use positive end expiratory pressure in the setting of mechanical ventilation is to keep the alveoli in a partially open state. This increases FRC, and of course, increase in FRC is going to increase oxygenation and gas exchange. And what is the advantage of keeping alveoli in a partially open state? So remember, if you compare two balloons, which is let us assume one is partially inflated already and one is completely collapsed. You know that this is easier to open up further. It's easy to blow up. But this balloon, which is completely collapsed, is going to take a lot of initial energy to open up, and then it becomes a bit easy. So if you look at the work of breathing, so this is much lesser in a partially inflated balloon. So you can remember that lungs are going to act like a balloon. And if you use a positive end expiratory pressure, it keeps the alveoli in a partially open state. That's technically going to reduce the work of breathing. And of course, it's going to increase the gas exchange. How it's going to do all these things? By reversing a complete atelectasis and by preventing collapse. And in fact, this has another added advantage by reducing a form of trauma called as atelectotrauma, because every time you completely collapse the lungs and if you inflate it again, so it's like crumbling a paper completely and opening up again. So this creates a lot of trauma in a diseased lung. So that's what we call as atelectotrauma. So by using PEEP, you can keep the lung in a partially open state so that you can prevent that complete collapse, so that you can avoid that atelectotrauma as well. So the right answer for this question is a simple, straightforward option A. Going to the 8th question, a 35-year-old patient present with sudden breathlessness, X-ray of the patient is shown. What is likely to be heard on auscultation? So this probably could be considered as a repeat question within the same shift. So you can see that the patient is having a pneumothorax. You can see the collapsed border of the lung here with hyperlucent areas in the pleural space, which is clearly suggestive of pneumothorax. And this patient is also having a bit of tracheal shift and a bit of mediastinal shift as well. So we can take this as attention pneumothorax as well. And in a pneumothorax, what you're going to expect, you're going to have absent sounds or reduced breath sounds on the involved side. And of course, if you look at the percussion, it's going to be hyperresonant, not simple. Let us move on to the next question. A patient present with headache and neck stiffness, CT scan of the head and CT angiogram is shown. What is the likely diagnosis? It's simple. So if you look at the CT, this is a very common CT that we have been discussing time and again. This is the star of death, that is subarachnoid hemorrhage, and you can notice a nice and beautiful berry aneurysm as well. So what's the likely diagnosis? It's going to be subarachnoid hemorrhage. It's like a spot. I don't want to discuss anything further. 10th question. A 45-year-old patient who presents with ptosis and muscle weakness was found to improve on rest. She was later diagnosed to have myasthenia gravis. Of course, they have given the diagnosis themselves. Now she complains of dysphagia and she has engorged veins on the thorax. CT scan is shown. What's the diagnosis? Look at the CT scan. There is an anterior mediastinal mass. In the context of myasthenia gravis, if you see an anterior mediastinal mass, it must be thymoma unless proved otherwise, because myasthenia gravis can be a paraneoplastic syndrome in approximately 15% of the cases, where the most common tumor that you encounter is going to be a thymoma. In the context of Lambert-Eaton myasthenic syndrome, probably you can think about a small cell cancer of the lung, which is seen in 50 to 80% of the cases, depending on the study you look at. But in the context of myasthenia gravis, when you see an anteromediastinal mass, 100% in exam, you're going to make a diagnosis of thymoma. But another extra edge point, if you want to know, remember the most common thymic abnormality in the setting of myasthenia gravis is going to be thymic hyperplasia and not thymoma, right? Okay, cool. Let us move on to the next question. A patient presented with ptosis and Horner syndrome. Ptosis is left out here. Sorry for that. And this ptosis is due to involvement of what? We know Horner syndrome is going to have 5 important components. Component 1 is ptosis because of loss of sympathetic supply to the Muller's muscle. And number 2 is going to be meiosis. And third is anhidrosis. Fourth one is going to be loss of ciliospinal reflex. And last but not the least, it's going to be the apparent enophthalmos, where the palpable fissure will appear smaller in patients with Horner syndrome. And of course, as I said, the answer is going to be A, because ptosis in Horner syndrome is due to loss of sympathetic supply to the Muller's muscle. LPS is important for opening the eyelids, and loss of third nerve supply to the LPS also can result in ptosis. But remember, this is not the reason for the ptosis in Horner syndrome. This is the reason for ptosis in third nerve palsy. So you open your eyelids voluntarily with the help of third nerve, and you close your eyelids voluntarily with the help of seventh nerve, because seventh nerve is going to supply orbicularis oculi, which is also a voluntary muscle. But Muller's muscle is an involuntary muscle, which is going to be important in closure of eyelids, especially during blinking process, right? So the ptosis in Horner syndrome is due to involvement of Muller's muscle. And coming to 12th question, a 21-year-old patient present with weakness, fatigue, hypotension, BP is 80 upon 60 millimeters of mercury, and reports show hyponatremia, hyperkalemia, and this patient also has hyperpigmentation in the knuckles, arms, and legs. What is the likely diagnosis? We have discussed 5 features. If it is there in exam, you cannot diagnose anything else apart from primary arterial insufficiency. What are those 5 features? Everything is there in the question. Fatigue, tiredness, weakness, hypotension, and tachycardia, which will be usually seen in patients with Addisonian crisis, hyponatremia, hyperkalemia, maybe a bit of normal and metabolic acidosis as well. And last but not the least, don't forget the hyperpigmentation component. So what about the other options? Like B12 deficiency can cause hyperpigmentation, but the presentation is nowhere near B12 deficiency. And Conn syndrome is something that's going to present with hypertension and hypokalemia, not hypotension and hyperkalemia. SADH can produce hyponatremia, but I don't think you can diagnose SADH in a patient who is having low BP, hypovolemia, and probably hyperkalemia. So that's gone as well. So right answer for this question, simple, straightforward, primary adrenal insufficiency, which is also called as Addison disease. So 13th question, it's an ABG based question. Again, a very, very easy one in this paper. So pH of 7.26, which means the patient is having acidosis. PaCO2 is decreased and bicarbonate is also decreased. By the Rome rule, we all know that if all the arrows are moving in the same direction, it's going to be metabolic acidosis. And of course, the right answer is going to be option A. If you want to go further, so you can understand that this PaCO2 of 16 is going to be because of compensation. So where the body is trying to compensate the acidosis by causing a respiratory alkalosis. And this patient is, of course, having a high anion gap as well. If you calculate the anion gap, what do you get? So sodium minus bicarbonate plus chloride. So what's going to be the sodium? It's 135 minus bicarbonate. We know already it's going to be 8 plus chloride is 108. So it's going to be 135 minus 116. So you get an anion gap of approximately 19. So we know that anything more than 12, it's going to be called as raised anion gap. So this patient is having a HAGMA, that is high anion gap metabolic acidosis with a compensatory respiratory alkalosis. Coming to 14th question, in type 1 diabetes mellitus, what is the feature of stage 3 beta cell destruction? So we have discussed this in many of our classes. In stage 1, what do you really see? In stage 1, the patient may have antibodies in the circulation, but the glycemic status will be normal. So we can say it's going to be normoglycemic, and the patient will be asymptomatic as well. What about stage 2? In stage 2, of course, antibodies will be positive. Patient starts to develop dysglycemia, but it will be more of intolerance range, not frank diabetes, and patient will be asymptomatic as well. In stage 3, antibodies will be positive, patient will be dysglycemic, and at this time, most of the patients will be having frank diabetes, which means the patient's sugar is going to meet the criteria for diagnosis of diabetes mellitus given by WHO, and patient will be symptomatic, where the patient starts experiencing all the osmotic and metabolic side effects of high glucose like polyuria, polydipsia, polyphagia, weight loss, and so on. So, of course, the answer for this question is going to be autoimmunity will be positive, patient will have dysglycemia, and patient will be, of course, symptomatic as well. And there is a drug called as teplizumab that can actually reduce the speed of progression from stage 2 to stage 3 in experimental models. Maybe if you want to know, you can think of it as a future question. 15th question, a woman at 8 weeks of gestation is diagnosed with hyperthyroidism. Which of the following is the most appropriate treatment option? One of the easiest questions in this paper. We know that in the first trimester, the drug of choice in a patient with Graves' disease or hyperthyroidism is going to be propylthiazole. And in the second and third trimester, probably you can switch back to carbimazole or methimazole, whichever feels good. And 16th question, a young woman presents with weight loss, tachycardia, heat intolerance, and tremors. She has exophthalmos on examination. What is the diagnosis? It's a very, very simple and straightforward Graves' disease, because patient is having thyrotoxic feature, and exophthalmos means it is a characteristic feature of Graves' disease. other diagnosis doesn't even come close to the presentation, right? Coming to this question, you have an 18-year-old female presenting with high fever and pain in knee and ankle joints, which means patient is having fever and arthritis. On examination, patient had a pansystolic murmur at the apex, which is very much suggestive of mitral regurgitation. Rheumatoid factor is negative. What is the diagnosis? So they have given a closed DD just to confuse you, that is seronegative RA, but with acute presentation and an 18-year-old with PSM at the time of presentation, I will not be really thinking about seronegative RA. So my diagnosis here is going to be acute rheumatic fever, which is very common in countries like India. So in fact, this fulfills the Jones criteria, right? Patients having, in fact, two major and one minor criteria, right? Fever is a minor criteria and arthritis and carditis is a major criteria. And in the setting of acute rheumatic fever, the most common form of carditis that you encounter is the endocarditis. And in the endocarditis, the most common problem is valvulitis. And in the valvulitis, the most common valve affected is the mitral valve. And when mitral valve is affected in the setting of acute rheumatic fever, the most common problem that you encounter is MR. That's mitral regurgitation. MS is a sequelae of acute rheumatic fever, and that we'll be calling it as rheumatic heart disease. So the right answer for this question is acute rheumatic fever. Here is a 44-year-old female who is a known case of scleroderma, presenting with shortness of breath, especially during exercise. She underwent right heart catheterization and their mean pulmonary artery pressure was 35 millimeters of mercury, which means we know that MPAP of more than 20 millimeters of mercury means we are dealing with a case of pulmonary hypertension. And in the setting of scleroderma, this pulmonary hypertension must be a type 1 pulmonary artery hypertension. The gold standard for the diagnosis and possibly deciding the treatment aspects of type 1 or any pulmonary hypertension is going to be the right heart catheterization, and that's what they have done. Right heart catheterization is also called as Van Gans catheterization, colloquially speaking. And which of the following is true regarding a condition? CCBs are the first line in all the patients is absolutely wrong, because CCBs are given selectively for those patients who are testing positive in the vasoreactivity testing. We have discussed that time and again. And we know that in patients who do not test positive, the vasoreactivity testing, we're going to use combination therapy. One of the best form of combination therapy is a combination of phosphodiesterase 5 inhibitor like tadalafil or sildenafil. Plus, we're going to use an endothelin receptor antagonist like bosentan, ambrisentan, or even macitentan in modern practice. So, endothelin receptor antagonist and various other drugs like phosphodiesterase 5 inhibitors and prostacyclin analogs are definitely going to improve symptoms and the functional status of the patient. Lung transplant is the best treatment if identified early is wrong, because it's very, very difficult to do a lung transplant in the setting of pulmonary hypertension for various reasons. And lifestyle modification is, of course, not going to be the best treatment because we're not dealing with the case of metabolic syndrome, aren't we? Let us move on to the 19th question. A 44-year-old male present with cough, chest X-ray revealed pleural effusion, thoracocentris was done, and the following was observed. Pleural fluid protein to serum protein ratio was 0.6. This itself confirms that we are dealing with an exudate. So as per the Light's criteria, whenever the pleural fluid to serum protein ratio is more than 50% and more than 0.5, that defines an exudate according to Light's criteria. And of course, some students say that they have given some value of LDH as well, but really that doesn't matter. If any one of the three Light's criteria is positive, we can say it's an exudate. And here clearly we are dealing with an exudate. Which of the following is the likely diagnosis? The only exudate that's given among the three is the pleural tuberculosis. All other three are basically transudates and not exudates, because cirrhosis is kind of RAS activated, CHF is kind of RAS activated, and nephrotic syndrome is also kind of RAS activated. So definitely these are going to be transudates and not exudates. So the only thing that fits into the exudative criteria, or maybe you can say exudative cause of pleural effusion among the given causes, is tuberculosis here. So that's the right answer. Easy one. 20th question, a mother brought her 2-year-old child to the OPD with complaints of lack of weight gain, abdominal pain on eating, and poor eating habits. The child was advised to follow a gluten-free diet, after which there was a significant improvement in the general condition and weight gain. What is the probable diagnosis? Of course, this is going to be celiac disease. One of the best screening test, or maybe even you can call it as a best serological test that you can do in the context of celiac disease is going to be your anti-TTG IgA test. And if they ask you the gold standard, of course, it's going to be endoscopy and biopsy. But trust me, even though they call it as a gold standard, but biopsy can be overlapping with multiple other diseases, including tropical sprue. But nevertheless, serological test, the best test, best screening test is going to be anti-TTG IgA. So here it's so simple, and it's going to be celiac disease. Don't diagnose tropical disease, tropical sprue, because tropical sprue is usually a diagnosis of exclusion. It is commonly seen in tropical countries. We don't know the exact reason, and most of the times tropical sprue is going to present with B12 deficiency rather than anything else. And A beta lipoproteinemia is not going to present like this. Patient will be having neurological problems, night blindness because of vitamin A deficiency, growth retardation, and patients will be having that characteristic acanthocytes in the peripheral smear. I think we have a question in the shift 2, if I'm not wrong. And Whipple's disease is going to present again in a very, very different way. So patient will be having dementia, cardiac involvement, and along with that patient might be having diarrhea and GI disturbances. But this patient is not having, I think, dementia or cardiac involvement. So I'm not going to make a diagnosis of Whipple's disease, which is basically caused by organism called as Trophiorma whipplei.